Thank you.
You're welcome.
Thank you.
Okay, thank you.
Chiropractic Council, Dr. Brian Ludwig, Albany District President.
Thank you for having me here to testify today. I testified in 2014 before the Workers' Compensation Fee Schedule hearing. I want to thank you for having that hearing. It was instrumental in Workers' Compensation Board.
Just for you.
Huh?
Nothing. Keep going. I said you're doing it. You did it just for us.
Yeah. Thanks. So yeah, that fee schedule is no longer going to be put into effect. Appreciate that. And we also want to thank you for proclaiming September as Chiropractic Health Month. We would like to draw your attention to some pending legislation. Again, we have the Medical Partnership Bill. We feel that that would be instrumental in changing the culture of healthcare in New York State. As I sit here and I listen, I've listened to other years when I've testified, we keep hearing about how there's more and more ill people, and there's increased cost with that, and if it's not handled at the local level, then it goes to the hospital level, and there's increased costs there. But what about just having fewer sick New Yorkers? You know, that would lower the cost for a lot of different things. In the past, I gave some testimony on Blue Cross Blue Shield of Chicago and how they reduce costs and things like that. And we can get into that more if you have some questions on how they reduced pharmaceutical costs by about 80%. I wonder how big the Medicaid budget is on just pharmaceutical costs. It's a funny question, but I know we know that answer. As a chiropractor, we start to think, and I'm looking at things that are promoted as health and healthy. And to me, that is the major issue, is that those things are not healthy, that are usually promoted as that. Quick fix of treating a symptom, not finding what was causing the symptom, leads to chronic illness, wasteful spending on healthcare, and it just spirals and spirals. Chiropractic can help New Yorkers achieve true health. We do it safely, naturally, and in a process can save the healthcare system lots of money. So if you want to spend less on prescription drugs, needle surgery, if your goal is to have fewer heroin addicts among young New Yorkers, you got to reach the person before they become an addict, before they become sick, before they become diseased. You must put and keep them on the road to good health. So how do you do that? Well, we heard some people today talk about good nutrition, smoking cessation, all great starts. A place that we keep going, and I keep saying this is not health, detecting an illness early is not preventing it. You first have to bring the person to be healthy before you can, if you do that, then they're not going to be sick and you're going to lower your costs that way. So we focus on the chiropractic, and the Chiropractic Council focuses on how the body works as a whole, without drugs, without surgery. So before early intervention, before detection, before screening, we don't pollute or modify the body chemically merely to mask symptoms. We help the body return to normal function. So it's like if you're driving down your car and you're going through the tunnel and you're listening to your radio, all of a sudden you can't hear the radio. Well, maybe the message to your radio isn't getting there. You don't need a new radio. You don't need to cut it out. Okay? You don't need to inject more electricity to it. You just need to get the message there. So that's what we do. We get the message there. From the brain to the body back up to the brain. So, a case in point, Medicaid, chiropractic care could substantially help many Medicaid-eligible New Yorkers, but we're unfunded. So I have Medicaid people coming to me, and they're paying out of pocket for preventative care, 100%. Why? I could have read the whole testimony, but I kept it to 5 minutes.
Thank you.
Thank you very much. Any questions?
Thank you.
Okay, thank you.
Rini Nogales, MPA, Nurse Family Partnership.
Good evening, Chairman Hannon, Chairwoman Young, Chairman Farrell, and other committee members. My name is Renee Nogales. I'm with the National Office of Nurse Family Partnership. And I want to start out by thanking the legislature for your support over the past 5 years for this program, without which we definitely wouldn't be where we are today. This year, we ask you to support $5 million in funding to support NFP, and in addition to this request, we're asking that you also support maintaining the COPS funding, Community Optional Preventive Services, which is an important funding source for NFP, and also to support funding for other home visiting programs, including $4.5 million for healthy families, $3 million for parents as teachers, and $1.5 million for the parent-child home program. But I'm here to talk about Nurse Family Partnership today. Many of you are already very familiar with this program, which is one of the largest and most extensively studied community health programs that transforms the lives of Medicaid-eligible women who are pregnant with their first child. They get partnered with nurses early in pregnancy, and the nurses work with them until their child is 2 years old to help them set goals for themselves, help them build their self-confidence, and help them achieve milestones. And we really believe that these nurses are helping reduce poverty one mother at a time. The Nurse Family Partnership is backed by decades of research, which show documented reductions in the use of public programs like Medicaid and food stamps, reductions in child maltreatment, better pregnancy outcomes, better language development for the children, and also better academic performance for the children. And over 38 years of ongoing research and development, which is continuing to today, is really showing positive results both with the mothers and the children, which really show that NFP is a dual generation strategy. For example, we see a 35% reduction in pregnancy-induced hypertension, a 67% reduction in behavioral intellectual problems by the time the child is 6, and a 59% reduction in arrests when the children are age 15. So there's a lot more details on the data and the program in my written testimony, including some client stories at the end. I hope you'll take an opportunity to read them, but I just want to wrap up by reading one very brief story. This is from a former NFP participant in New York City named Donna Freeman. I learned about NFP from a caseworker at my shelter. I'm usually pretty open-minded, so I thought I'd give this a try. My nurse, Joanne, helped me in so many ways. She gave me confidence as a mother, helped me create a real relationship with my daughter, taught me what it means to be nurturing. I would never have thought about reading to her or teaching her to play with crayons, but now Zaira is 5 years old, and she's so smart, and she loves to write. She's doing really well in kindergarten. I felt like NFP was my family, extended family, better than my real family in some ways. Raising a child is stressful, especially when they get sick. That baby messes with your mood. You can feel really alone, but I always had someone to talk to, and the right someone, because Joanne is a nurse and she knew what to tell me. She was always positive and helpful. She taught me everything I needed to know, and I always felt heard with her. Plus, Joanne built up my self-esteem, not just as a mother, but as a human being. Now I know I'm worth a lot. I'm working as a police officer in DHS now, which is the New York City Department of Homeless Services, and it's very challenging, but I use all the lessons I learned from NFP about patience and compassion every day. I get so inspired when I have a chance to meet these families, so I hope you'll enjoy the other stories. I just want to thank you all again for your continued support, and I can answer any questions if you have them.
Thank you very much. Questions? Thank you.
Thank you.
Thank you.
Kim Atkins, Board Chairman, Family Planning Advocates.
Thank you for the opportunity to testify today.
My name is Kim Atkins, and I'm the board chair of Family Planning Advocates of New York State, as well as the CEO of Planned Parenthood Mohawk-Hudson. Family Planning Advocates represents New York's family planning provider network, including Planned Parenthoods, hospital-based, county-based, and freestanding family planning centers that collectively represent an integral part of New York's healthcare safety net. Family planning centers provide vital primary and preventive care services that include full reproductive care, testing, treatment, and counseling for STDs, including HIV, breast and cervical cancer screening, family planning that often includes basic primary care for women. In 2010, more than 6 in 10 women obtaining care at a family planning center considered it their usual source of care. For 4 in 10, it was their only source of care. Despite a continual decline in unattended pregnancy, New York remains one of 3 states with the highest unattended pregnancy rates in the nation. And in the absence of publicly funded family planning services, the rate of unattended pregnancy and abortion in New York would be 32% higher. By redoubling efforts to advance access to family planning services, we can improve the health of our communities, better positioning individuals to explore and achieve their educational, economic, and family aspirations. With that in mind, Family Planning Advocates asked the legislature to allocate an additional $2.4 million in funding for the Family Planning Grant to bolster the ability of grantees to continue providing these critical health services and connecting individuals to health coverage. This request reflects the $750,000 in funding the Assembly has added in the last several budget cycles and an additional $1.65 million adjusted for inflation, which was reduced in the 2013-2014 enacted budget. The cost savings achieved through publicly funded family planning services are simply undeniable. By assisting clients in avoiding unattended pregnancies, reproductive cancers, and STIs, New York's publicly funded family planning centers saved $605 million in public funds in 2010. As the state continues to implement innovative approaches to improving health and reducing costs, doubling down on effective programs like family planning is the strategic investment in future health and economic stability of the state. We'd also like to urge the legislature to restore COLA funding that was cut in the governor's budget. So the funding level contained within the enacted 2015-16 budget. $2.3 million reduction in COLA funding absolutely hinders family planning providers from hiring the kind of qualified healthcare professionals, especially in this time of healthcare reform, and there's a lot of change going on, and we need to pay our providers what they're worth, and also handle the increasing costs of healthcare benefits and other things that are impacting the delivery of service. So I understand the COLA budget is a formula, but it's really important to acknowledge that not everybody's affected by the CPI in the same way, and that it's important to have quality healthcare providers providing services. And finally, I'd like to just make a case for transformation funding for safety net community healthcare providers, one of which is a family planning provider, but also community health centers and other behavioral health providers in the community. As we collectively move towards the high-quality coordinated healthcare delivery system that emphasizes that right care be delivered at the right time and in the right location, it is imperative that access to vital services be ensured within communities across the state. Community healthcare providers, including family planning agencies, are essential partners in these efforts. Many of these providers are small agencies with lean operating budgets, challenged by years of stagnant or reduced funding pools and increased cost of operation. Engagement in transformation initiatives necessitates resources not currently present within these agencies or flowing from the performing provider system lead agencies, or state-designated funding streams that support capital or working capital needs. The state's dependence on the community-based healthcare provider network for the successful transformation of the delivery system must be matched with reasonable investment in this provider network. So in concert with other community health providers, we recommend that a minimum of 25% of the $195 million healthcare facility transformation program funding be allocated to community healthcare providers, including family planning, behavioral health, and home health agencies, as well as FQHCs. This amount reflects the goal of DSRIP to reduce avoidable hospitalizations by 25%. And two, the establishment of a new funding pool in the amount of $88.5 million entitled the Essential Community Health Care Provider Fund. This funding should be solely available to community health care providers, and the purpose is in direct alignment with the funding pool in last year's budget to support the capital and working capital needs of these providers. With that, I just want to acknowledge that we are thankful for the continued funding of the Comprehensive Adolescent Pregnancy Prevention Grant at the current level, and welcome the governor's funding commitment for a statewide plan to increase the state's breast cancer screening rate by 10% over the next 5 years. Thank you.
Thank you. Questions? Have a good evening.
Thank you.
Sure. Linda Ragnar, Frank Kaprupa, New York State Association of County Health Officials. Yes, good evening.
Good evening.
Good evening.
My name is Frank Ruppin. I'm the Public Health Director and Mental Health Commissioner of Tompkins County. I also serve as the County Health Officials of New York Vice President, a statewide association also known as NYSHO. With me is Linda Wagner, our Executive Director, and Dr. Sherlita Amler from Westchester County sends her regards. She was unable to attend. The work of local health departments has been very visible over the last year, dealing with emerging communicable diseases such as Ebola, Legionnaire's disease, and now Zika disease, among others. Most of our work, however, is much less visible, and our time is spent touching almost all of the issues you've heard presented by other speakers today. And we serve as the foundation of health in our local communities. We are requesting your help and support to reinforce that foundation by making a change to the state aid formula in Article 6, Section 605 of the Public Health Law. Article 6 provides a base grant to local health departments, either a flat amount of $500,000 for smaller partial service counties or $650,000 for more populous counties. Since the population in New York City, Nassau, and Suffolk counties is so much larger, their base grant is a per capita amount of 65 cents per person. This amount is higher than the flat base grant would be, but 65 cents per person is a low per capita rate. With the base grant, 100% of allowed local expenses for core public health activities can be reimbursed. Beyond that base grant, local expenditures can be reimbursed at a 36% rate. So we are asking your support in making changes to Article 6 state aid in two ways. First, we're requesting that an increase to the base grant from $500,000 to $550,000 for partial service counties. Also, an increase from $650,000 to $750,000 for full service counties, and provide $1.30 for every resident in the larger counties and in New York City. This rate would be more equitable for the city, Nassau, and Suffolk counties, and it would add Westchester, Erie, and Monroe counties to the higher per capita base rate. Our second request is that you provide local health departments with an increase of 2% from 36% to 38% in the Article 6 state aid reimbursement rate. These increases will help us achieve the goals that we've been asked to address, including DSRIP, amongst many others, and we seek your support in helping us reinforce the foundation of local county health departments. Thank you, and I'd be happy to answer any questions.
Any questions?
Good, got the point. Thank you.
Yes.
Good stuff.
Very effective. Thank you.
Thank you very much. Kathleen Killan, Assistant Director, New York State Area Health Education Center System.
Hi there. My name's Kathleen Callan. I'm the Assistant Director of the New York State Area Health Education Center System, which we refer to as AHEC. So glad to be with you tonight. Several of you are AHEC supporters and champions, and we are so thankful for your support. I'm here today relieved that we are put in the budget for level funding this year. There's no cuts. There's no buckets. There's no consolidation. This is a great day for us. I don't mean to.
I don't like the buckets neither.
Yeah, I know, and you were so supportive, and we want to say thank you to the legislature last year for turning back the buckets and the cuts. Your state, the state funding helps our 9 centers, our 3 regional offices, prepare the next generation of health professionals that are going to work in our underserved communities. We are about 1/3 funded by the state. That serves as the match to our federal funding. That's another 1/3. And then the last 1/3 of our funding is other grants that you'll hear about throughout my testimony, things that we get on our own that the state and federal funding helps sustain. I want you to know, though, that I wouldn't be fair to say that we have adequate funding and we can't turn back all the primary care shortages in New York State that we're facing and that you are all well aware of in both rural and urban areas. We are focused on grow our own programs, taking middle school, high school, college students, even some career change professionals, and turning them to the opportunities, the many opportunities that are in the medical professions and the health-related professions. You've heard all today about the many transformation programs going on in New York State. DSRIP, FIP, SHIP. None of these are possible without adequate staffing. And we are involved in many of the PPSs, and we are a consistent voice in those PPSs and with the Department of Health, reminding them that we need to think about the future health professionals that are coming up, and we need to invest in that. Just trying to summarize here. Okay, so on the next page and in our annual report, which you have in front of you, you can see that we worked with nearly 13,000 elementary, middle school, high school students. We work with college students. We work with medical students, nursing students, health profession students who are going through their rotations, exposing them to an underserved community, and also recruiting those students and supporting those students from underserved communities to help the overall diversity of New York State. We continue to do continuing education programs that you can see listed here, and we also collect short-term, intermediate, and long-term impacts, and you can see that as well. I guess the best way to talk about AHEC is to talk to our students. I invite you all on February 3rd. We have an open house in 711A. Some of our students will be coming there and talking to you about their experiences, about the mentorship that AHEC offers, about the exposure that they got to health careers that they had never considered, and their commitment to working in underserved communities. Thank you so much for your support.
No.
Thank you very much.
Thanks for your good share.
Thank you.
Leslie Grubler, Founding Director of United New York Intervention Providers and Parents and Partners. And after that is Daniel Lowenstein, Brian O'Malley next, and then Amy Lowenstein. If you get closer to the table, it'll move faster.
Good evening. My name is Leslie Grubler from the United New York Early Intervention Providers and Parents as Partners. I know it's a mouthful. Thank you all for being here this evening. I so appreciate you staying for the testimony. It's not by accident that I have this statement on the cover. Dr. King was a fighter for liberation, not unlike our families and our providers. And UNYEIP represents not only the families, but also the independent contractors, all the folks who are on the front lines in treating children of early intervention, those 0 to 3. I'm going to be very brief and just address the points that were in the EI reforms of the executive's budget. The first point is screenings. Screenings are just that. They don't tend to tell everything. They're not comprehensive. They don't give us all the data, and they could very well mislead. And that's an important component. If they're being added mandatorily to the process, we may actually end up spending more rather than less. The second piece is there was questions about the family-directed evaluations and the question of resources or the exploration of resources of a family. You should know that these types of evaluations are already done in New York City, and they're done basically to determine whether there's appropriate support in the family. That is, if there's caregivers, if mom and dad work, if they have individuals who are supporting them, grandparents, extended families, etc. We have never found it in New York City to be problematic. I'm not sure of what the executive's perspective is here. I am a little bit concerned about the wording because resources can be looked at from a financial perspective as well. So I think perhaps in reevaluating the paperwork, either we change that word or we just delete the entire idea. The medical records component as being used to determine eligibility, we know that typically medical records are written by physicians. Not every physician has a bent on developmental disorders or developmental delays. They're not able to describe, and they don't know what type of treatment to recommend. Think of yourselves, those of you who may have gone to physical therapy. Could your physician, your general practitioner, tell you exactly what exercises to do to relieve your pain or distress, etc.? Likely not. But your physical therapist could, not unlike something a speech-language pathologist like myself could do, or an occupational therapist as well. So we have to be mindful of that. The language in the reforms reflects a 1% increase in the administrative function. That would mean that none of the hands-on providers typically would have the opportunity to partake of that unless they were an independent contractor. The 1% is 1% of the administrative costs. If we consider that to be 20% of the rate, that would come to about 10 to 16 cents per session, or a per annum increase of about $344 a year. If you take a look at the testimony, I've included some charts in the back that reflect that since 1993, the inception of the program, there's been a cost of living increase of 64.58%. The next chart reflects, or I should say the previous chart, what the decreases in rate were, anywhere between 15 and 20% as well. So it's just important to note that while that 1% is helpful, it's 1% of administrative costs, which is significantly less. It probably could pay for a cup of coffee at Dunkin' Donuts, I think, maybe every day. So early intervention families, they've been unknowingly sacrificed by a system that has not only dismissed the vulnerability of the children's conditions, but has dismissed the evidence-based practice that supports and enables their children's progress. There were questions as to waiting lists. Yes, they still occur. There was questions as to whether the lists the early intervention DOH department has are accurate. We know that they're not. We've known that for 3 years, and those lists have still not been made accurate. I'm not quite sure what is taking all of the time in ensuring that they are accurate. A couple of other comments on prompt pay and what I call prompt say. The prompt pay provisions, which I indicate on Chapter 4, are great. However, the 90 days must start from the time of authorizations because service coordinators do not process that paperwork on a timely basis, and the 90 days is then ticking away. Prompt Say, again, is also very good. However, presently the SFA has no capacity to update data in NICE. They must refer this change to the provider, who then must relay the information to the service coordinator. So if we're going to make change happen, and if we really want to make this system efficient, then we need to go all the way. My last comment, and that's on the last page, is that I think we need to recognize that the system, it's the system, and I'm speaking of the NICE system, is a dinosaur system. And still to this day, almost 3 years after the inception of the fiscal agent, there are insurmountable inefficiencies. If we want to attract good providers back into the system, then we need to really look at rebranding the DOH and the early intervention program so that it is, again, meaningful to the children that we service. And that's really all that I have to say today. Any questions at all?
Thank you very much.
Thank
Any
you.
questions? Yes. Yes.
You said attract back into the system. My understanding is a lot of providers have left the system because of the process. Can you just very briefly tell us your experience, how many have left, and why?
Yeah, 45% of providers since 2013 have left the system. And that's what is, in fact, yielding the waiting lists that we have. So here we know that early intervention will help our children, will perhaps take them from disability to ability, and we're dismissing that. And it's not something that we can dismiss. And as I said on the cover here, our lives begin to end when we become silent about things that matter. Our children matter. Our most vulnerable children matter. And we have to start making them a priority. Thank you.
Thank you.